Hi, everyone. It is my pleasure to introduce our speakers for today, Dr. Lane and Dr. Suwanabol. Dr. Lane is a fifth-year plastic surgery resident at the University of Michigan with a research and clinical interest in gender-affirming care. Prior to residency, she graduated from the University of Michigan Medical School. During residency, she obtained a master's in health and healthcare research through the National Clinician Scholars Program. She has published on outcomes and access to gender-affirming surgery in JAMA Surgery, and the New England Journal of Medicine, and has presented at both national and international meetings. Dr. Pasithorn Amy Suwanabol is an associate professor of surgery at the University of Michigan. Dr. Suwanabol received her MD and completed her general surgery residency at the University of Wisconsin and her fellowship in colon and rectal surgery at the University of Massachusetts Memorial Hospital Medical Center. In 2015, she joined the faculty of the University of Michigan. Her research focuses on optimizing palliative care delivery and quality of life for surgical patients. She has received funding from the National Institute on Aging, Agency for Healthcare Research and Quality, and serves as a co-PI for the National Cancer Institute study focused on survivorship among younger adults with colorectal cancer. Above all, Dr. Suwanabol values her roles as a staff surgeon at the Ann Arbor VA serving our nation's veterans and as the Director of Medical Student Research at the Center for Healthcare Policy and Outcomes, which allows her to guide and mentor the next generation of clinician-scientists. I'll let Dr. Lane and Dr. Suwanabol take it away.
Great. Thank you so much for having us. As introduced, my name is Megan. I'm one of the plastic surgery residents at Michigan. And Dr. Suwanabol, if you want to introduce yourself real fast.
Yeah. So thanks for joining us this evening, everyone. I know this is a little bit of a newer topic for everybody, but this is an important issue, and this is something that's going to be addressed more and more, including on your guys' exams. So I would strongly encourage you guys to reach out to folks who are about to start thinking about their exams and get some of this information because it's important. And it's also important just because there are going to be more and more people that you're going to be encountering who may be impacted by this, or have undergone surgery or are thinking about surgery. So thanks for inviting us. We're excited to be able to share some of the information with you guys.
Great. So with that, we will get started. So the big things we'll kind of talk about over the next hour is kind of a general introduction to gender-affirming care and surgery. I understand probably the exposure to this particular field of medicine is probably very broad and diverse in this group. So we'll kind of talk from the basics and then kind of go a little bit more focused into what you as a colorectal surgeon may need to know or may need to be familiar with, either for exams or for your clinical practice. We'll talk a little bit about some of the process of getting gender-affirming surgery, and then we'll talk about some common situations where colorectal surgery may be involved, specifically intraoperative rectal injury, neovaginal fistula, and then some points about long-term follow-up and cancer risk. So to start, I just wanted to talk very briefly about what gender-affirming care is and kind of some just basic definitions. So gender-affirming care is really a constellation of different therapies that help align a person's kind of physical appearance with their gender identity. This particular field is very multidisciplinary. Reviewing these slides even today, I definitely left some fields out, but to be a gender-affirming provider, you can be many different surgical as well as non-surgical subspecialties. And so the care of these patients really involves a multidisciplinary team. We'll talk about some just basic definitions related to gender and gender-affirming care. Here are just some definitions that we may talk a little bit about during this lecture, but are important to know when talking to patients and talking about gender and sexual orientation. So now many people talk about sex assigned at birth. So that's the biologic sex that is usually assigned based upon external genitalia. Gender identity is someone's concept of being male, female, non-binary, another gender. And that is what people perceive themselves to be and what they call themselves. Gender expression is the actual outward appearance that someone has. And then a lot of times, sometimes people confuse sexual orientation and gender identity, but they are really two different things. So sexual orientation is really your attraction towards another person. And then just to have kind of a working definition of what being trans or transgender is. It's really kind of an umbrella term, and you'll kind of hear us talk about being trans. We're going to use that as an umbrella term, meaning those individuals who are a different gender than the one that they were assigned at birth. And so that is separate, and really importantly for this talk, that is separate from sexual orientation, which is really your attraction to another person rather than your own gender identity. So we just want to talk a little bit about the demographics of trans individuals in the United States. So this is kind of a moving target, but generally speaking, in the United States, the estimated number of individuals who are trans is about 0.5%. In the younger demographics, that is slightly higher, anywhere from 2 to 5% is reported. And it should be noted that the number of gender-affirming procedures in the United States has increased significantly over the past 20 years. Many people attribute this to the ACA and their Sex Non-Discrimination Act within it. But one big thing to note is that there are more and more people that are seeking these operations in general. This is maybe relevant, but the most commonly performed gender-affirming procedure is mastectomy for transmasculine people, and the most common procedure for trans feminine people is vaginoplasty. I just want to talk very briefly about kind of caring for trans patients in general, and just some basic principles whenever you're seeing, any patient really. But I think the biggest thing first off is just creating and maintaining a culture where all people are welcome, and making sure that using people's correct names and pronouns is just an expectation. This is something that can be continuously worked on in any healthcare setting, and that's something you as the attending surgeon can really demonstrate to people that this is an important thing that everyone should be working on. Another thing is just ensuring that documentation is accurate. It's really easy to use smart phrases, but one thing to know is that those smart phrases may include incorrect pronouns or dead names of people. So just making sure when you're seeing trans and gender diverse people that you're using the correct names and pronouns in your documentation, because other providers may not take the time to ask about those things and may just copy your work. And then the other big thing is not assuming and actually asking. So one thing to really know is that not all trans people and gender diverse people want medical, or need, I should say, medical or surgical therapy to affirm their gender. So you really shouldn't make any assumptions about what types of organs people have for care, what types of procedures people want, or what type of medical therapy they're on. So it's always good to ask if it's relevant. And the last thing that I would say, particularly for people that either staffing as attending, is just making sure to always keep your differential broad. So just because a person is gender diverse doesn't mean that their chief complaint may be directly related to their gender identity. So this is something called trans broken arm syndrome, but essentially just making sure that if you are seeing someone in the ER, for example, for abdominal pain, making sure that you're ruling out all their other things that may not be related to their gender identity or the procedures that they had for gender affirming surgery. And so we wanted to go over, in the last slide, we talked about not assuming and asking. So we just wanted to give this slide, it's very busy, but just some general tips about how to ask, particularly about sexual orientation in our talk. So the biggest thing is just asking about people's partners, what gender identities they are, what sexual practices do people prefer, what protection do they use from STIs? Do they have a history of STIs? And then do they have any intention of becoming pregnant? And kind of related to that, a lot of times within EMRs now, there's also the opportunity to take what's called an organ inventory. So even asking patients, just generally what types of procedures they've had can really get to people's pregnancy risk or other risks of these types of things. But this is really a busy slide. Feel free to screenshot it. But here's just some questions that are kind of developed by the CDC about asking about sexual orientation and sexual behavior specifically. And now we're going to kind of get into the nitty gritty of things. So I wanted to just very briefly talk about some of the procedures that are considered gender affirming surgery. So for transmasculine people, and that's individuals that were assigned female at birth and have more masculine appearing gender identities, some of the procedures that people may choose to have include things like mastectomy, hysterectomy, an oophorectomy, a metoidioplasty or phalloplasty. For people that are trans feminine, so people that were assigned male at birth who are more feminine appearing or are more feminine identifying, that includes things like facial feminization, breast augmentation, vaginoplasty, and orchiectomy. So importantly, once again, people that are gender diverse may choose to have one of these procedures, none of these procedures, or a few of these procedures. So it's always important to ask if it's clinically relevant. So I just wanted to talk also really fast about just the general process of getting gender affirming surgery. It's just relatively complex, and it may be something that does come up on your exams. I know that it comes up on the plastic surgery side of things sometimes. So generally people have to kind of know about these operations and that these are actually a possibility. And I should say that this is kind of also my research interest, so I put a slide about it. And then they actually have to talk to a therapist or other provider that is well-versed in the diagnosis of gender dysphoria. That is actually a requirement that we'll talk about on the next slide. But this is kind of a different thing that isn't really required for most other areas of surgery. So people do have to talk to a therapist or another professional. They do need to get a letter that talks about their gender identity and a few other points that we'll talk about in the next slide. They then have to find a surgeon. So the reality is there's actually not that many gender affirming surgeons in the United States. So that for many people can be difficult. Insurance needs to be determined. So that's another issue. There's a lot of variability depending on the state that you live in, whether some of these procedures will be covered by your insurance or not, or whether or not you need to pay out of pocket. Finally get surgery, and then the aftercare. So this is a relatively complex kind of series of steps that people have to go through before getting these operations. So kind of as I alluded to before, so for gender affirming surgery, there's actually some criteria that people need to meet. This is called the Professional Association for Transgender Health. This gets updated every few years. So the current version is called the Standards of Care 8, version 8, which is a little bit different than the Standards of Care version 7. Things are, in version 7, things are a little bit more well-defined, and in version 8, there's a little bit more flexibility in terms of what is required. So really, people need some documentation of persistent gender incongruence or gender dysphoria. Patients that have mental health comorbidities, they need to be under good control prior to surgery, and people need to be on a stable medical hormone regimen if they're on one. So these are a little bit more flexible than previous versions. If you do get a question about this, previous versions actually required a certain amount of time to be living as a gender role, as well as a specific amount of time for hormone therapy. So things just generally are more flexible, a little bit less defined by the actual months that these things need to happen. And so we're going to talk, and we're going to kind of transition into kind of vaginoplasty. That's the procedure as colorectal surgeons you're going to see the most. And to kind of introduce some of the things we're going to be talking about, this is kind of like very much plastic surgery 101, but I just wanted to kind of review very quickly what the difference between a graft and a flap is. Because we'll be talking about different types of vaginoplasties, and some rely on grafts and some rely on flaps. And also some of the complications that we'll talk about will be managed by flaps as well. So a graft generally does not have its own blood supply. So it's a piece of tissue that is cut off from its native blood supply and then is placed onto another area. It's usually bolstered on, and essentially it lives through this process called ambition and inosculation. So, and then finally revascularization. So over the first 48 hours, the tissue kind of lives from nutrients that are kind of eluted from the underlying wound bed. And the next 48 hours, the blood cells and the blood vessels from the graft start to quote unquote kiss the underlying vasculature, and then finally revascularization, the graft starts to actually revascularize. Flaps actually have an independent blood supply, so they are not detached from their native blood supply, and flaps can be named, and that blood supply can actually be a named anatomic vessel that's relatively predictable. There's also things called random pattern flaps, so that's kind of what you see, like that's what a Z-plasty is, or that's when many of the kind of skin flaps that we do are actually random pattern flaps. So that kind of comes up when we're going to be talking about vaginoplasty, and we're going to talk about a few different types. There's really kind of three main types, and then kind of this other kind of smaller subset that we'll talk about. The most common in the United States is called the penile inversion vaginoplasty. There's also the peritoneal flap or graft vaginoplasty. There's intestinal vaginoplasty. And then finally, there's zero depth vaginoplasty or a vulvoplasty. And so we'll kind of go through each one of these and some of the anatomic points to these procedures. So penile inversion vaginoplasty, and I should say kind of generally when thinking about vaginoplasty, kind of the shortcut is thinking about the embryologic parts that kind of create a penis or a phallus and kind of matching them up to what vulva looks like. So generally speaking, for the vulvoplasty or kind of the external genitalia, we're going to be taking the parts of the penis that would kind of embryologically match up to the portion of the vulva. So we're taking the glands of the penis and we're going to be making it the clitoris. We're going to be shortening the urethra. Depending on the technique, we'll talk about how the vaginal canal is made, but that's kind of where the big variation comes in. Some of the scrotal skin becomes the labia majora. The labia minora, depending on the institution, is actually created in a few different ways, and that's kind of a technical point. But essentially what we're doing is we're going to be deconstructing the penis and making them those parts. So kind of just to talk a little bit about penile anatomy and some of the points. Let me see if I can get a pointer here. I don't use Zoom very often. Here we go. There we go. Can you see my mouse?
Yep.
Cool. Great. So generally speaking, so the glands of the penis is going to really be isolated on these vessels and nerves here. So that's the dorsal artery. There's two of them, the dorsal vein, and then the dorsal nerve. So that's going to supply the clitoris. We're going to take out the corpora cavernosum, which is the erectile tissue. We shorten the urethra, and we actually will take the skin of the penis and we will use it. And I should say institutionally at Michigan, this may be different where different people go, but the skin of the penis usually makes the opening or the introitus of the vagina. The rest of the vagina is actually going to be surfaced by a skin graft created using scrotal skin. The actual space where this dissection is going to occur is going to basically be at the base of the bulbospongiosis, where it kind of meets the transverse perineal muscles. And that space is going to be dissected in the plane of the Denonvier's fascia. So essentially, you're going to be kind of going along the pelvic floor muscles and ultimately go between the rectum and the prostate. Depending on the institution, this may be done different ways and with different subspecialties kind of participating in this operation. At some places, this procedure is done by urology, and some places done by plastic surgery, but the PIV is a generally open approach. I'm going to just go over the next slide and kind of talk a little bit more. And I should say during the PIV, the bulbospongiosis is usually removed. The corpus spongiosum, which is the muscle surrounding the urethra, depending on the institution, they may skeletalize or kind of try to remove some of that, and other places they keep it. And here's just an illustration of kind of the different parts and what they become. So the green, if you can look, actually, it's just going from kind of the glands of the penis. The blue is going to become the clitoris. The red is kind of showing the labia minora. The green is going to become the introitus. The pink is actually a little flap that we make basically like perineal skin. It's kind of like a little triangle. So that also forms a portion of the introitus. A portion of the scrotal skin becomes labia majora, and then that yellow is actually a skin graft. And then we keep it in place using a bolster. And depending on the institution, that bolster may be made from different things. Some people use a wound vac, some people use a traditional kind of packing. And then the image over here is just kind of showing where that space actually lies. So a really important technical point, or a really high yield, I would say very testable point is that patients that have a vaginoplasty will have a prostate. So that's a really important thing kind of long-term to know for these patients. And as you can see that this is actually a pretty tight space. So you're kind of, we're kind of shortening the urethra in the area of the bulbar urethra. And we're really dissecting along kind of the prostate and the rectum. So, you're not going to have a lot of tissue there. So, for patients that have PIVs, really kind of the mucosal, they don't really have a lot of mucosal tissue there. It's really skin graft on a very thin layer of fascia there. We'll go on to peritoneal flat vaginoplasty. I think Dr. Suwanabol kind of talk a little bit about that one.
Yeah, just because I help support the plastic surgery team at Michigan doing the robotic approach. We at Michigan do them as secondary procedures. So for folks who have developed vaginal stenosis, it's a complication that Megan will talk about shortly. This procedure was actually developed not that long ago, a robotic peritoneal flat vaginoplasty. Now, this was initially developed as a Davidoff procedure for people with vaginal agenesis, but has since been developed fairly recently at NYU and has been kind of spreading throughout the world and across the United States to help with those who develop vaginal stenosis after a penile inversion vaginoplasty. So in doing this, again, we at Michigan only are doing this for secondaries, not primaries, but there are folks who are doing this for primary vaginoplasties. It's essentially the same thing. And you guys can see in the imaging here, can you see my mouse? Probably not. I think I can, I can annotate here. So again, if this is the space where the neovagina is placed, right? So the peritoneal flap allows you to really essentially create the apex of the neovagina. And so what you're doing is as a robotic approach, it can either be done with a single port or it can be done with multiple ports. I personally don't do single port, and I'll just use just as like how we do a low anterior resection or, rectopexy, I'll just put the port straight across the abdomen and then basically create anterior flaps over the bladder. Can you see this? Can you see this?
Yeah.
Okay, perfect. So this is the anterior flap. This is the posterior flap here. And what you do is there's a tunnel that's created right here where Denon VAs is. The tube of the skin is brought through this area. So you basically dissect right in front of the prostate, try not to get into any bleeding or anything. And then the tube is basically there's a tube of vagina that you sew to this here anteriorly for the anterior flap. And then what you do is secure this in place and then sew this together to kind of create the rest of the apex. It's a little bit hard to describe in just a two-dimensional way without any dynamic movements, but essentially that's what's happening is that you're creating this anterior with just that B right here and then the posterior here. But you can understand how people can potentially get into injury because you're so close to the rectum. And, when we're doing APRs, this can be a very dangerous area, right? So then I'll let Megan continue on, but I'm certainly happy to answer questions. This is just important for you guys to know because as, a robotic surgeon, you may be assisting some folks with this, or you may be helping with some kind of robotic or repairs of any rectal injuries in the future.
And then we'll talk a little bit about intestinal vaginoplasty. So these are not generally performed a ton in the United States. They're usually performed, and it's actually kind of really like a flap because you're going to be taking kind of a portion usually of the right colon to create the vaginal canal. And I should say for both the peritoneal flap vaginoplasty as well as the intestinal vaginoplasty, so the portions of the vulva are kind of generally the same. But yes, usually you're taking a piece of right colon. There are some studies and some people have used small intestine as well for this. And so that is another option, although it's not usually performed in the US. There's not very many centers that do this.
Yeah, and I'll just add, it's actually the sigmoid colon that people are taking, and then they use like the sigmoidal branches to keep it as your blood supply to the area. It's done through either like a fan and steel or like off midline little incision just to try to mobilize it, and it can be mobilized laparoscopically. Sometimes colorectal surgeons are involved. Sometimes it's the urologists who are comfortable doing laparoscopic surgery helping with this. And one other thing to point out is that the reason why people may prefer to use this technique is because it self-lubricates. But there can be issues with using an intestine as a neovagina, which I think, Megan, you're going to talk about shortly. Is that right?
Yeah, I think so.
Okay.
We'll talk about that. Yeah. So, and then just to mention, there's also something called vulvoplasty or zero depth vaginoplasty. This is similar to a PIV or penile inversion vaginoplasty, but the vaginal canal is just not created. This could be done for many different purposes. Could be patient preference, issues with dilation. So for patients that have PIVs or penile inversion vaginoplasties, they have to actually dilate multiple times a day or risk having vaginal stenosis. This is also an option for patients that have a history of pelvic radiation or prostatectomy. So we'll kind of talk just very generally about considerations. There's a bunch of different reasons to choose one vaginoplasty type over another. One big thing is the amount of penile and scrotal skin. So for patients that do not have a lot of penile or scrotal skin, particularly patients that are pubertally suppressed or didn't go through a traditional male puberty, they do not have a lot of skin. So using something like a peritoneal flap vaginoplasty is usually a better option. As I mentioned, previous surgery, particularly prostatectomy, limits what can be safely performed for these patients. Weight is another issue. So there are some centers that do have very strict BMI cutoffs for different types of vaginoplasty. And then there's also patient preference. So kind of as Dr. Suwanabol mentioned, for some patients that are particularly interested in self-lubrication, for example, they may try to find a surgeon that can do intestinal vaginoplasty. So those are just some of the things that come up. And we'll kind of move on to complications and things that you may see as a colorectal surgeon. So there are a few different intraoperative complications. There's bleeding, obviously, from multiple different areas. You can have a urethral injury that you can recognize at the time. So really this is happening when there's a dissection of the vaginal canal. So you're really trying to ride the adenomvenous fascia. So you can have a urethral injury, you can have a prostatic injury causing a significant amount of bleeding. You can have a rectal injury, and then you can also have, particularly for the intestinal as well as the peritoneal flap, vaginoplasties, intra-abdominal injury as well. And we'll kind of talk about some of these. So intraoperative rectal injury is a very feared complication of this procedure, particularly for plastic surgeons, many of whom have not done a general surgery residency. So there are multiple different things that we do, and we'll kind of talk about an algorithm. This is going to be very institutional specific. Every institution does this a little bit differently. So I will say some institutions do require patients to have a bowel prep prior to this procedure, not all of them. There are some steps that some institutions take with every single procedure to determine if there is an injury, and we'll talk a little bit about that. If an injury is recognized, we do try to repair it at the time. Usually that's performed either by the operating surgeon or working with our colorectal colleagues. There are some institutions that actually will save the bulbous spongiosus muscle until the vaginal canal is dissected. In case of a vaginal injury or a rectal injury, they can place that kind of as an extra layer as well. So that has been something that has been described as well. This is going to be a super busy slide, but there is a paper that talks about kind of an algorithm for not only recognizing injury, but also management of rectal injuries. And I will say, so this was published out of the University of Michigan. So we do a bowel prep. Intraoperatively, we actually will do a betadine enema, where we will place a lap into the vaginal canal and then perform an enema and see if there's any betadine on the lap itself. And then post-operatively, so let's say that there's no betadine in the packing, these patients will have like a bolster in place. Here, it's vaginal packing. We leave that in for 5 days, and then after that, we will take it out. And the big thing we are looking for is stool on that vaginal packing. So that's another thing that we're kind of looking for. If there is a rectal injury noted, we try to repair it primarily. If there are any concerns or if it's considered a large injury, we would get our colorectal colleagues involved. And then there are a few things that we have done, including if there is an injury, we're not going to advance their diet super fast. I will say in plastic surgery, we're pretty quick to advance people's diets. So we take it a little slow, we do NPO for a few days, clears, things that you guys normally do, that we as plastic surgeons think it's a little different than what we normally would do for most of our postoperative patients. And so, the biggest thing too is that for these patients, a lot of times we're going to still have them dilate the vaginal canal to help make sure that it doesn't stenose down, which can cause kind of issues down the line, which we'll talk a little bit about. But, the biggest short-term complication we're always worried about is rectal injury. I don't know, Dr. Suwanabol, if you have anything to add about this?
Yeah, I think, and I guess, with a prepped, it's the same thing with any other kind of rectal injury from any other operation, right? You just have to consider, do I need to divert the person or not? Is this dirty? Is this a large injury? Do you think that you're going to have a potential leak, and whether or not you'd want to leave a drain intra-abdominal or anything, or, scope intraoperatively? So I just think those are the considerations. It is really clinical. It's really dependent on the type of injury, how much is injured, whether the person was bowel prepped, and whether or not you think they can tolerate, a leak. And of course, this is the biggest risk for developing rectovaginal fistula, which we'll talk about shortly.
And then we'll kind of talk a little bit. So early postoperative complications, most of these are these are very common, but usually pretty minor. So it's very normal for patients to have some type of wound breakdown, particularly along their labia majora. That's something that usually is managed via local wound care. There's always a chance of flap necrosis. So usually that's actually like the labia necrosing. Granulation tissue is super common, particularly in the vaginal canal, and that's something that's normally treated with topical silver nitrate. And then voiding dysfunction in the early postoperative period is very common. So particularly issues just with the urine stream, not sicking kind of straight down in the toilet, so spraying while you urinate. Generally, we advise patients that does get better over the first 6 months as the urethra kind of reduces in swelling. So we do have a good number of many of these early complications are pretty manageable. Delayed complications are, these are kind of some of the more serious things for many patients. So vaginal stenosis, this is particularly common if patients don't dilate. This can require revisions. So as Dr. Suwanabol said, here at Michigan, we're doing peritoneal flat vaginoplasty in the setting of revision cases. So patients will need some type of revision if they do have vaginal stenosis. For patients that have intestinal vaginoplasty, many of them can have mucorrhea. They can have a foul odor. They can even get diversion colitis within their vagina. For patients that have a urethral injury, some of them can get kind of urinary tract fistulas. For patients that have rectal injury, they can get rectovaginal fistulas. And then finally, there can be vaginal prolapse in kind of any of these cases, either with the graft or the intestinal vaginoplasty. We'll kind of talk a little bit about rectovaginal fistula. So this complication is kind of the most feared. The actual rate is very variable in the literature. It's kind of anywhere from 0.45 to 4.5% of patients. Generally speaking, most people say it's about 1 in 100 patients. Fistula, once again, is about 1 in 100 patients. And really the big thing we're looking for is patients reporting either stool from the vagina or gas. There isn't a ton of literature, but many people do say that a rectal injury is a high predictor of a fistula. And I should say that these are relatively rare, so most of the papers are case series. And this next slide is going to be pretty busy, but we recently published, or we are kind of in the process of publishing a book chapter that kind of talks about some of these case studies. So in terms of the management of fistulas, one really important thing to think about is that this neovagina is skin, so it's not vaginal mucosa. In addition to that, it's an operative field. So you're kind of already, when you're thinking about fistula repair and management, you're kind of already at disadvantage because you're working in a scarred space that may not have the same properties as mucosa. For some cases, and I should say that most of this literature is just case series or case reports, we found 9 cases where fistulectomy and repair was performed, and it was successful in 6 out of 9 cases. And it's difficult because, you're kind of working with different size fistulas potentially. A lot of these patients did require diversion for ultimate management of their fistula. And many of these patients did require flaps, particularly gracilis flap, for complete resolution of their fistula. Dr. Suwanabol, I don't know if you have anything to add or any kind of thoughts on this.
Yeah, I think really as, colorectal surgeons who, seen, pretty typical fistulas from either obstetric injury or from cryptoglandular disease, this is very different, right? This is just, the neovagina is essentially just skin. It's a tube of skin laying over top of the rectum. And so you don't have the same one, it's not the same traumatic injury or the same, cause of why this happens. And also you have to remember that it also is just there's no layers, right? So the vagina, has multiple layers, the rectum has multiple layers, but this is just skin. And so you have to think about this a little bit different. Your typical, putting somebody on, bowel or fiber and trying to just manage this conservatively is probably not going to work. And even, doing an advancement flap may not be super successful, right? And even, this having a rectovaginal fistula can lead to other complications, like having stenosis later on. So I just want to make sure that we, it's very different than having what we typically think about with a rectovaginal fistula or even an anorectal fistula from cryptoglandular disease. Oh, you're muted, Megan.
Sorry. So yeah, we'll kind of go over kind of the management of a fistula. And I think I'll hand it over to you, Dr. Suwanabol.
Yeah, no, sounds good. So this picture, I'm not sure if you can see it super well, but what you can see is you can see the probe right here going through it, right? So you can see, here it is, the bottom of it, but what you can see is that it's going through right where the transversus muscle is, so the vagina through the rectum. And so what you'll see for the next image is that they're going to make an incision over this area to try to get to that fistula tract. Can you advance to the next one, Megan? And again, opening to the fistula tract, which would probably be something like this. Okay, next slide. And then this is where you would get your plastic surgery colleagues, just like what we do APRs, and we ask them to harvest the gracilis. I'll have Megan describe this to you if you've never seen this.
Yeah, I don't know. Have you guys talked about this in your other lectures, gracilis flaps?
Not in detail. So
Yeah, so this is a super common flap. I would say also, once again, for APR defects, may be very institutionally based, but this is definitely a workhorse flap amongst our patients. So this is a gracilis flap, generally taken from the thigh, or I should say this taken from the thigh. In terms of the markings and kind of general things we talk about, so the blood supply is going to be the median femoral circumflex artery. There's actually also a branch of the obturator nerve that you can take with it. We don't usually think about that for APR defects, but we actually use this muscle too for facial reanimation. This flap generally is taken along an incision. You'll see if your plastic surgery colleagues kind of palpating the thigh, and we're looking for the adductor longus. We can actually look at that, and the gracilis is going to be directly posterior to it. And then we will usually make an incision along the upper portion, kind of upper 1/3 or so of the muscle, and then a counter incision, or we may just make a long incision along the thigh. And the pedicle to this flap, and I should mention, I don't know if this will ever come up, but it may. This flap type is a type 2 or Matheson to high type 2, meaning that there's one dominant pedicle and there's another smaller pedicle that this muscle can't live on. But essentially, we'll kind of disinsert it from the medial aspect of the thigh, and then we'll bring it up kind of into the peritoneal space. And the inset's actually right here. The pedicle itself is about 10 centimeters from the ischium. So that's something we'll kind of look for. So this is kind of the insert. This usually is lifted up. So the muscle's kind of lifted up, and then we will tunnel it through a subcutaneous space to bring it into the perineum. And then we'll inset it where it needs to go. But it's a really nice flap. It's really nice. It's the patient's in lithotomy. It's right there. It's a fun flap. But yeah, so this is a nice example of taking some healthy tissue and putting it into that space and adding extra layers there. And here's the closure. So you see that there's a drain in the thigh. There's also one in the perineum as well, in a Foley.
Yeah, and I can talk about a little bit about vaginal prolapse. So this happens typically when we have intestinal or intestinal vaginoplasties. This can happen because you remember this isn't surrounded by anal sphincters, right? It's literally just surrounded, posteriorly is the rectum, right? So this is just what you'll see basically this mucosa prolapsing out. And so there's a couple different ways that you can approach this. Of course, just like when we do regular rectal prolapses, you can do a perineal approach and try to reduce some of this prolapsing tissue, but it might recur, right? So it's not as durable of an operation. The more durable operation might be doing something intra-abdominally, where if this is the piece of intestine, you would basically try to pexy this onto what they describe as either the psoas muscle or somewhere where you can, is it possible to try to suture it onto the presacral fascia like we do for rectal prolapse. So again, you may see this and your plastic surgery or your gender surgeons may ask you, how can we help manage this? And you might have to just resect some of this locally, or you might have to do a more durable approach, which would be an intra-abdominal approach, either again, open laparoscopically or robotically, but to secure that to either the psoas tendon or the presacral fascia. I can continue on. Megan, does that work? Okay, perfect. So some things we just wanted to make sure, remember, there are a couple things about working with transgender patients. You have to remember an individual's patient's anatomy. You remember, as with any kind of patient that you're encountering, you want to make sure you understand their surgical history and then understanding their sexual practices, because that does help in terms of follow up and determining risk of developing other cancers, right? So remember the 5 Ps that Megan had brought up earlier, which is how to talk about sexual practices for patients so you can understand their risk and almost normalize this conversation. The other thing is remember that people who undergo vaginoplasty still have their prostate and still require prostate cancer screening. Same thing goes for people who've had intestinal vaginoplasties, right? So if it's the colon that still needs to be surveyed, right, or surveilled. There have been few cases of people who develop squamous cell cancer and penile inversion vaginoplasty about 20 years post-op, and then there is a theoretical increased risk of developing HPV as well. Unfortunately, at this point, there are really no specific guidelines for transgender patients regarding colonoscopy for intestinal vaginoplasty or HPV screening for such patients. But what I think we could do is probably just apply some of these, the existing guidelines at this point until we have better data. So I think I'm going to take this opportunity just because I did a very similar talk a couple months ago, and I think it's always important. This is very much fair game on your board exam. And this is just to reinforce some things that you guys may think, oh, it's not as important as understanding rectal cancer or colon cancer, but this is important. Again, it's fair game, and you do have to know this as a colorectal surgeon. So STIs, just not STDs, so sexually transmitted infections, disproportionately affect men who have sex with men and transgender and gender diverse individuals who are already at higher risk of healthcare disparities, partly due to stigma and discrimination in medical settings. And so you as a colorectal surgeon may encounter individuals with proctitis, and you may see these individuals in your practice. Can you go on to the next slide? Some things to think about. So how you may develop anorectal infections will be associated with some certain sexual practices. It's not just anal receptive intercourse. So it's important to know that there are a number of different sexual practices that can be associated with anorectal infections, including, again, anal receptive intercourse or oral anal contact, in addition to fisting or fingering, or nudging or dipping. So just make sure that you feel comfortable or understand that there are other ways to be infected with an STI, and it's not just, again, anal receptive intercourse. So again, as the colorectal surgeon, what you might have come to you is that somebody in their office might be complaining of proctitis or anal pain, and I think having this as have a high index of suspicion. So an anal infection can be infection from the stratified squamous epithelium of the anus. This can be from HPV, HSV, and syphilis. Those are the most common. Or you can get proctitis, or infection of the entire anus and rectum. And those are predominantly among those who have anal exposure. So again, not just anal receptive intercourse, but other means of sexual practices that can be associated with anorectal infections. Those are oftentimes gonorrhea or chlamydia, also HSV or syphilis. Those are the most common. Next slide. In those with HIV or other immunosuppression, I think it's always important to remember that CMV or other opportunistic organisms can be responsible for this. And how the next slide will show you how most patients may present. So anal infections, they'll come in with pain, itching, discharge, bleeding, or perianal lesion. For proctitis, you might get mucopurulent anal discharge, anal rectal bleeding, anal rectal pain, or anal rectal itching, constipation, a sensation of rectal fullness, or incomplete defecation, tenesmus, or mucus streaking in the stool. Next slide. This is really important. Again, this is a very, very much fair game. So when you have an anorectal infection, it's important to know when you're thinking about what protects you from anal infection is that the anus is the primary mode of protection of invasive pathogens is the integrity of the mucosa and the skin. Any kind of trauma will abrade the mucus lining and deliver pathogens directly into the crypts and the columnar cells in the anus. So your Langerhans cells or your dendritic cells will mediate the cellular immunity to prime the T cells to identify foreign antigens. This will allow certain pathogens to alter the balance of the cellular elements. So the things to remember are that HPV increases your dendritic cells and combines with your host genome to evade surveillance. And then HIV decreases the dendritic cells and depletes the T cells. But the combination of HPV and HIV further suppresses the dendritic cells and decreases the T cells. So what happens is that's why HPV can persist and cause progression to dysplasia or carcinoma. So that's something to remember. Again, HPV increases their dendritic cells, but HIV decreases and then also depletes. But the combination of the two causes a further decrease in dendritic cells, T cells, and then the HPV can persist and cause develop into dysplasia or carcinoma. So that's something that's important for you guys to remember for your exams. Next slide. So the challenge of encountering an individual with an anal infection or proctitis is that oftentimes the signs and symptoms are more related to the organ rather than the organism that's causing this. And oftentimes it's more than just one organism. It can be multiple organisms. You can have co-infection with both chlamydia and gonorrhea. And then it's unclear whether it's really the true organism that's causing this problem or the colonizing organism. The other challenge of this is that there's not a lot of rapid tests that are available that are also sensitive. So most often we treat empirically. We'll take the next slide. So if you encounter a patient with, purulence, discharge, pain, tenesmus, and you have a high index of suspicion because you've done your 5 Ps, you should just treat empirically. You treat both for chlamydia and gonorrhea, and you just treat with ceftriaxone and doxycycline until your rectal swabs, your anal swabs come back, and then you can treat accordingly. If it's somebody with proctitis or enterocolitis, then you treat for the direct pathogen. And this is from the CDC guidelines. This is a summary of just treatments. I don't recall if you're expected to know the entire treatment regimens for all of these things, but I think understanding empiric treatment for somebody who comes in with an anal infection or proctitis who you have a high index of suspicion, it's wise for you to remember that doxycycline and what was the other one I said? I don't even remember myself. Ceftriaxone are the empiric treatments for these people. Yeah, thank you. For all comers, not just, I recognize we're in a transgender surgery talk, but again, this is just for anybody you have high suspicion for. And again, I just wanted to reiterate this. And then other management considerations when you think about when you're treating for anal infections, you want to tell the patient and have them tell their partner that they should be abstaining from sex for until treated for 7 days and the symptoms resolve. You want to test all persons with active proctitis and suspicion for STI you want to treat all persons with active proctitis and a suspicion for STI for HIV, syphilis, gonorrhea, and chlamydia. So make sure you're testing all for the potential organisms. You want to encourage good hygiene, and then you also want to evaluate, treat, and test the other partners. So I think that's all we have for today for you guys. We're happy to take questions.
That was fantastic. Thank you so much.
Second that, it was really great. We do have one question in the chat coming from Dr. Angel Reyes. He's interested specifically in wondering about some more of the long-term complications of the intestinal conduit. And so, for instance, he says that they have seen an obstruction of the conduit from insipation of the secretions and also perforation. And also, the secondary question is potential for referral to a tertiary institution in these cases.
Yeah, so unfortunately, we don't do any of the intestinal vaginoplasty at Michigan, but it's not outside of the realm of possibility that can happen, right? That it's probably a very rare occurrence where you do get the inspissated stool or mucus in the neovagina, especially if things are not evacuating, and potentially it can cause bacterial overgrowth and obstruction. So I can see that happening. If that does happen, of course, you'd want to send the person to a place that would be comfortable managing this. Particularly, a place which would be able to manage a very ill person and somebody who would be able to resect this completely. But if you're not comfortable, stabilize the person and then potentially call a gender surgeon who might be familiar with this operation. I don't know, Megan, if you have any other thoughts about somebody with intestinal vaginoplasty coming with obstruction perforation.
Yeah, I mean, I think what Dr. Suwanabol said in terms of transferring the patient to a higher tertiary care center, I think that makes total sense, and trying to find a gender surgeon that manages these patients, because as Dr. Suwanabol said, it's pretty rare in the US. And so being able to talk with folks that do have that experience, I think would be good.
One question that I had off of his question was, is there any, I know you guys don't do that, type of surgery, but is there any particular protocol for like irrigations or maintenance that you guys know of, being familiar with that?
So I will say that in general, actually, there is kind of a protocol, even for penile inversion vaginoplasty for vaginal rinses. These are going to vary based upon the institution, but generally for us, we have people rinse their vaginal vault with warm soapy water twice a day for at least, I believe, 6 weeks. So each institution is different, but we do usually recommend some hygiene to the area in the form of vaginal rinses, because even with the penile inversion vaginoplasty, there is skin slough and that can cause kind of some discharge. So that's one area to keep it clean. I am not familiar with the specific postoperative protocols for intestinal vaginoplasty.
Yeah. I mean, I would assume that if you have diversion colitis of the conduit, you would maybe add some short chain fatty acids in there too, but I can only hypothesize.
Yeah, I mean, I don't know either, and I would be completely guessing as well when you hear about the diversion colitis, how one would want to manage that, right? So I would too would think, would one do short-term fatty acids? I've also heard some folks say they don't actually believe that the diversion colitis actually happens, and it might be something else going on. So
Yeah.
it just, it's unclear what the actual symptoms are, because again, this is fairly new and we don't do a ton of them here. So I think right now, it's a lot of case series, just like Megan has suggested. And I think doing the best you can. If you're not sure, you can scope, right? Just like we would do with a a sigmoid that was in the correct or not correct, I apologize, in the traditional anatomic position, right? Is that you would just scope and try to see what was going on and see if you needed to treat it. I think just knowing that that I think for you guys, knowing that it's out there, right? That there may
Hmm.
be people who have intestinal vaginoplasties, and that, while I have not heard this yet, there is a real risk that this can turn into cancer, right? We know younger and younger people are getting cancer, and it would even suggest that it's not just young people who are undergoing these operations either, right? It's a diverse group of people who are undergoing these operations, and we know that colorectal cancer is very much present, and it's important not to forget that that is a risk, right, for those sigmoid vaginoplasties.
I'm assuming that the screening guidelines would fall in line with just normal screening as well.
Yeah, and like we said, we don't have any specifics for the transgender population, so I would use the same for a non transgender patient, the same screening guidelines, right? For normal risk, 45 years of age, and then
Yeah.
anybody high risk, right? We would do it earlier. Yeah.
Okay. I had a question actually. With these types of surgeries, do you ever see concomitant pelvic floor dysfunction or levator ani syndrome? And then does pelvic floor physiotherapy still hold a nice benefit? Yeah,
Yes.
it's not.
So I would say that depending on the institution, there are some institutions where each patient will actually meet with pelvic floor prior to their surgery, and then it's patients are prepared to get pelvic floor PT following their operation. There are other institutions where if patients are having symptoms of vulvodynia or having issues with dilation or chronic pelvic pain, then they'll be referred. But pelvic floor PT definitely is a huge part of this operation, and particularly postoperative management. But yeah, to the point where there are some institutions where that's part of their preoperative workup is they'll go and see a pelvic floor physical therapist.
Right.
Yeah. And the prevalence of pelvic floor dysfunction, even in the pre-op setting amongst this population, is fairly high already. So then you can imagine with the dissection in that space, right, that can potentially worsen or exacerbate some issues, some already underlying issues.
I think that's pretty much it that's in the Sir John chat. And that's you guys actually ended up answering all the questions that I had amassed during the actual presentation. So thank you guys so much. It was a really great talk.
Oh, it's our pleasure.
Thanks.
Thanks for having us.
Thank you again.